Save My Piggies, Your Life, Your Limb, Your Story, with host Dr. John Phillips and Kim McNicholas.
Hi, everyone, and welcome back to the show. We are sharing Thomas's story. Thomas is alongside his new cardiothoracic surgeon. He is fighting to save Thomas's leg, and they're both working together on this. Thomas, you were sharing that you had multiple bypasses done, a femoral popliteal bypass, which is from the thigh to just below the knee, as well as a fem-fem bypass, which is rerouting blood flow from one leg to another. And then on top of that, you ended up with a little, what you described as roto-rooting, where they go in with wires and balloons and maybe what they call an atherectomy device, which is a plaque removal device, and remove some of that plaque. How are you doing now, or how are you doing, let's say, following that?
Do you mean from when I started seeing Dr. Allie?
No, before Dr. Allie, because we're going to get to what led to Dr. Allie.
Right. Well, it was a couple of weeks later, I had a home health nurse coming out, and they would come around and do my dressings. And, you know, they told me I could get up, I could walk to the bathroom, which is only a short distance away, but I got a different pain this time. I was getting like a shooting pain coming up from my toes on the right leg, right up to my groin. And it was a real weird feeling. It wasn't a pain, it was more a sore, but it was in the groin area. And then 2 weeks after that, I went back for a follow-up. When I went to follow up with my surgeon, I got to his office and I was told, you won't be seeing your surgeon today. He's no longer with us. He's gone somewhere else. And I kind of got upset and I thought, oh boy, did something go wrong with it? And I've seen another surgeon. I believe it was a surgeon up above this surgeon who did my surgery. And he told me I had infection at the time. That was the first thing he told me. I had infection in the groin. And he told me the only way that we will remove that graft that we put in is if the graft becomes infected. And this went on for like several months. I panicked because the surgery, what it had done to me. And I was so afraid I was going to lose my leg, or, you know, and it built up on me. Well, anyway, after I believe it was after maybe 4 to 6 weeks, they told me the graft had failed. Both of them, the fem-fem and the fem-pop had failed.
So, Thomas, if I could interject, because I want to hear from Dr. Allie, just so we can get a little bit more color behind this. So I guess a couple of thoughts that come to mind. Maybe the first surgeon was a locums and was just kind of spending a little bit of time there. And then the second thing, Dr. Allie, I'd like to hear from your thoughts. So presumably the incision got infected, and then that ultimately led to the graft. Maybe it failed because of outflow issues, but then the graft got infected also?
Well, guys, tell me when I'll come in with some clinical stuff, because you're close, but you're not exactly right on all of this from the standpoint of medically and what I was faced with and what I decided to do for him.
I'd love to hear.
Yeah,
we'd love to hear from that point. Yeah, no, exactly. We'd love, because we're just guessing.
We're pretty good guessers.
Well, yes, you are, and so was I, and that's always good to have luck on your side, okay? But there's things that had to be proven one way or the other. So Thomas is a fellow who was a smoker. He was not a bad diabetic, and that is important because he never had digital ischemia, and that is hard to overcome. He had a normal kind of atherosclerotic process in which smoking in relatively small vessels for a male, and he was suffering from PAD symptoms for several years. And as I look back on this, he had significant disease. It was kind of identified, and the treatment finally came, it appeared, when he had really had a occlusion worsening some of his chronic disease. That brought his symptoms on, but they weren't at his toe. Many of your audience is going to be diabetics The normal thing is it starts from the toes up. That, luckily for Thomas, was not his case. His ischemia was to the muscles and into the larger blood vessels. Now, with that said, when he went in for treatment, I believe, he was seen by vascular surgeons who I will say, I would hint are adequate and were good, yet he was very complex. This was a very complex anatomy that he presented to these physicians. That same kind of case had presented, let's say, to somebody who had more endovascular training or skills to do things with wires versus open surgery. I see that all the time, and I'm lucky enough to have a staff in which we can correct most things like Thomas without ever having to go to open surgery. Now, that doesn't mean there's not a place for open surgery, because there occasionally is. In his case, he did not have anatomy and the situation that was conducive to fixing without an open surgery. They made an appropriate decision, I think, in their hands, that they would now offer him surgery because they were concerned about the limb. They chose a fem-pop bypass, which is complex. I have done them. They are recognized procedures, but they are complex, and there are risks and benefits. And one of the things that Thomas suffered from was, first of all, his revascularization, or the bypass, did not work the way that was proposed, and I doubt that it worked very long at all. So in their attempts to correct his circulation, he had an open surgery procedures. Anybody who has these open surgery procedures have a risk for the wounds not healing where the incisions were at. He had a long bunch of incisions. There was, even if this had worked, it had 10 to 20% chance that he may have kind of a wound complication. That goes back to one of the reasons why it is always, in 2023, we should have endovascular procedures, which are non-surgical procedures, in almost every patient as the first line of treatment that will revascularize and save most of these patients without an open surgery.
Dr. Allie, I hate to interrupt you, but we're going to go to break. But I also want to just make sure I heard that correctly. As a surgeon, you're suggesting we should go to endo first. I mean, I do endo first because I don't have the opportunity to flip, but I like what I hear. And
well, it's not brand new. This goes back to the days of Tom Fogarty, Ted Dietrich. In other words, we have the surgeons who realize this are. They're few, but there's more now than there used to be. And so I think it should be well accepted, even by most surgeons, okay, who now have those and are taught those skills because they weren't before, that the patients out there ought to go somewhere where no matter which physician you see, it should be optimal that all endovascular non-surgical treatments are offered first. And that's what you saw.
You are so preaching to the choir here. We love you, Dr. Allie. Coming up next, right here on the Heart of Innovation, we'll have more with our Save My Piggy special, and we'll continue Thomas's story.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. This is our Save My Piggy special. We have Thomas here, who's been sharing his limb-saving story alongside his cardiothoracic surgeon, Dr. David Allie, and we're going to get to the point where Dr. David Allie started treating him in this segment. It's a short segment, but let's just get to the point. You ended up getting in touch with the Way to My Heart, which is our leg-saving nonprofit organization, and our nurse practitioner at the time said, Thomas, you have this infection. I need you to go right now to the emergency room and get some antibiotics. You said, okay, I'm going to go to my local hospital. I'm going to get the antibiotics. And what happened while you were there? They said, we're not just going to give you antibiotics. We're going to cut you open again, right?
Yeah. Yes, that's right. They told me I didn't have no infection. But they put 22 vials of antibiotics through an IV.
But you
A
had no
couple-
infection.
No, I had no infection.
That's what
No,
they said.
absolutely none. And
Huh.
but you could see it. It was oozing. It was brown. It was all colors. It was really hot. It was nasty, and it
And this was
smelled
at the
like it.
incision site of your last bypass.
Yes,
Right.
ma'am. Yes, it was. And it was just above the knee where there was one little cut, I guess, where they come down from the groin down there. And there was like an area where I've got like a 3-inch scar. And then down below the knee, that was above the knee, the 3-inch scar. And then the one the one below the knee was about 6 inches.
Wow.
They were
And
both
so-
infected.
And so you actually in this moment decided, I'm not doing any more cuts. I'm going to do as the way to my heart suggested. I'm going to go get a second opinion. And that's when you went to Dr. David Allie. You checked yourself out and said, I need another doctor.
Yeah, this was actually a third opinion because I had the second
Third.
surgeon. The strange thing was they kept telling me, you need a bypass, you need a bypass. I said, I just had a bypass there. And they're like, no, you're going to lose your leg. We're going to end up having to amputate it if you don't do this bypass. Well, in the end of it all,
So Thomas, when you decided you've had enough, wanted your third opinion, and real quick, what did the doctors think when you said that? Hey, I'm leaving. What did
they told me I was refusing treatment, which I wasn't. I wanted that opinion, that third opinion. I have that right to it. And I asked about the antibiotics, why they were pumping so many antibiotics through me if I didn't have infection. And then my main concern was they wanted to do a surgery again, and I had infection, which would end up spreading right through my whole body. Well, anyway, long story short, from this guy that I've seen up at ER, he told me, like, you're refusing treatment. The surgeon's back tomorrow. I said, no. I said, I'm going home. I'm going back to work. You know, I was adamant. And after that, no, they won't see me at all up there.
And so, Dr. Allie, you jumped in, and what did you find when he went to see you?
Okay, guys. So he presented to me. He's described surgical incisions that were about to completely fall apart. So when he came to me, the first thing I had to do was to try to determine whether or not this guy needed an amputation. Because in truth, if his graft was infected, it would have to be removed, and at that point he would have had to have an amputation. And what is also not said here is he's had multiple knee procedures. So there was a lot of things going on there, and I had to determine whether this was superficial or deep infection of the graft. Now, he happened to land in my hands, and as a surgeon, I also happen to do advanced wound care. I'm hyperbaric certified. I do all of these other things that are ideal for wound care also. I determined, because he wasn't diabetic, he had no ischemic on his toes, that if his wound was superficial and it was superficially infected, which it was, that is different than a deep infection. So I had to prove to myself, and this was done by quick testing, including an MRI. This meant that he did not have a deep infection. Everything was superficial, and if I could get him some additional blood flow and treat his wound, then he didn't have to have an amputation, but that he would need complex wound care, skin grafts, all of those things, which I was willing to do. And understand, Thomas could still walk. So he did not have anything that did not give me the time. So I also wanted to see if I could help him with revascularization without surgery. So I did an angiogram, which means I took him to the cath lab from the arm, and I sought ways to help him with wires. The answer is he had no wire accessibility to revascularize him.
So, Dr. Allie, I'm gonna. Sorry to interrupt you, sir. I'm gonna have you stop right there. We need to go to break, but once we come back, you're gonna finish the story for us. So, stay tuned, please.
All right.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
So we only have about 5 minutes left. Dr. Allie, you were beginning to tell us about your kind of treatment plan for Thomas. But before you do that, and I hope you get, or at least get into it, because you had told us before the show started that you had never seen a case like this. So expand on that, please.
I'll do that. Can I do that now?
Please.
Yes.
So to the audience, he presented with infection, ischemia without blood flow, draining wounds, the possibility of graft infection, knee space infection. The reason I'm telling you that is because almost every case like this would have already had an amputation. And that was what he was probably looking at, but because I don't think he had any abilities to have revascularization. Now, with that said, so that puts him at the end of the whole scope, and I see patients at the end, but most of those patients, again, have digital wounds. They have things that cannot, that rapidly go into gangrene. He had ischemia, which means a lack of blood flow, but he wasn't in acute need for an amputation, nor revascularization, nor anything at that moment, in my opinion. So we took an angiogram. He had no options to get him more blood flow. Not, in my opinion, not surgical and not with wires. So therefore, I was focusing on a massive wound in a patient who didn't have much blood flow. But I felt, because of my clinical experience and what I'm seeing, is that he had enough blood flow to heal his wound if we could keep it from getting a deep infection, because he could still walk. So I had to make a decision. Was I going to take this on? Because there's people who are looking at somebody like myself. Is he doing too much? Is this really a non-salvageable situation? So I made a clinical decision that I think I could work with this patient for those medical reasons. And I had a patient who looked me in the eye, and he seriously wanted to save his leg. I had Kim McNicholas. I had the foundation. I had them Ubering him back and forth. It wasn't just David Allie. So I was compelled to help this gentleman and go through the process, starting to treat the superficial infection, treat the wound, do the best I can with those skills, because I had those other skills, but they weren't applicable to him.
So David, we've got less than a minute left. So tell us where you're at right now with his wound care.
So I made a decision, and we did complex debridements. I proved that it was superficial. I put on split thickness skin grafting. We now have this thing almost completely healed. He walks, he get around. I met his wife. And may I throw in that during this several month period of time, I was in the hospital myself, the floor below Thomas, with acute kidney stones. Thomas, you remember that?
Calling the shots
Yes,
to help Thomas. It was amazing.
And so this was a very complex case. This deserves the audience understanding. Get multiple opinions from multiple physicians. Rely on Kim. She knows who can do the wires, do the stents, do the surgeries, do the wound care. And this is a very complex case. And at this moment, we got a fellow who's smiling. He don't have no cigarettes. He's responded. We've got him on maximum anticoagulation. His wound is almost completely healed. And to my knowledge, we're going to get it healed. And I will continue.
That's fantastic. I have to ask, Thomas, did you lose any digits, or have your piggies been saved?
My piggies have been saved, every one of them.
And the very first question I ask him every time I walk in is, "How's your toes?" Because you understand that now puts it in a different category.
Yep. And so now, do we have a long-term leg saving possibility here?
Yes, we do. We do. He has no imminent wounds. Now, he got to take care of his toes, because if he does have a wound, if he has something like that, he has very little
30
flow.
seconds.
enough to save his leg, enough to keep him ambulatory and walking, have a smile on his face, and enjoy his life. The wound care has been complex. He has allowed it to happen. I have provided it, and here we are today.
Thank you so much, Dr. David, Allie. We really appreciate you. Thank you, Thomas, for sharing your story.
That's fine.
Thank you, all of you, for joining us on our Save My Piggy special. Have a great weekend, everyone.
Take care.